This lecture is about public health institutions and systems in Kuwait. Before I deliver the lecture, أنا عبد الرحمن الدوسري، أنا طبيب وعندي ماجستير ودكتوراه في الصحة العامة في إدارة الخدمات الصحية Health Policy and Management. I am the Deputy Director of MBK Children's Hospital في وزارة الصحة. Okay, so health systems. I think in your previous lecture you took by Dr. Junaid, health systems. So before we start about the Kuwait health system, what is a health system? It's the total sum of all organizations, institutions, and resources whose primary purpose is to improve health. So this would include, for example, healthcare workers. They are part of the health system. Healthcare facilities, healthcare departments, government departments, funding bodies, the money we put in healthcare to provide healthcare. Healthcare industry firms like pharmaceutical companies and the general public if they contribute to health. So a health system should أنا ترى مو مرتاح ما أدري وين أشوف في ريموت.
لا.
So the health systems.
نقدر احنا نسوي
هذا بس حق بيخالف. Okay, so ترى احنا ما عندنا وايد وقت. So health system should aim to meet all health needs of the population it serves within the constraints of time, of cost, and quality. And this is not an easy task. This is challenging. Why? Because health needs of the population are changing. The health needs we cater for today in Kuwait health system are necessarily different from what they were 20 or 30 years ago. The disease pattern 20 years ago was different. We have, for example, today, less communicable disease. We have more, for example, malignancies, more non-communicable diseases, more chronic conditions than we had 30 years ago. And the population today is aging, so we have more disease of the elderly than we had 30 or 40 years ago. Also, it is challenging because different players, different actors of the health system have different priorities. So some players, I mean anybody that contributes to health, that influences the health system. So some would want to save money, and others would want to receive all health care, regardless of cost, and so on. So we have competing interests, competing priorities in the health system. Also, healthcare is a service, and managing services in general is challenging. Services, any transaction that does not result in a tangible product. So we have, fine now, thank you. We have products and services. Healthcare is a service, so it is more challenging. Services are intangible. We do not have something that we can touch or taste in healthcare. It's a service, and it's heterogeneous. So each time we receive a service, in general, all services, even a coffee shop is a service. So every time we go to the coffee shop, our experience may be slightly different because of the human factor that is involved in generating this service. Also, services have something called inseparability. So production and consumption are inseparable. Unlike products where they are first produced and we can store them if they are good, or discard the bad ones, and then only serve what is upon demand, the good ones. We do not have this with services. So we have simultaneous production and consumption together. The service is produced as it is consumed. And they're perishable, so we can't store them. We can't inventory. We can't, in low peak, in low demand days or hours, create healthcare, then serve it upon demand. Okay? And managing service is challenging, and managing health service is even more challenging, because the demand for healthcare is actually a demand for health. Nobody would want healthcare. Nobody would want to go to the doctor. Working on the laptop. Nobody would want to go to the doctor to receive an injection or have an operation. They all want something else, a derived demand from health, for health. And also there is information asymmetry. The amount of information between the client, the healthcare user, and the provider are different. The patient, the healthcare user, know very little about their health need, or whether they need to see the healthcare provider, than the doctor. So the provider, the doctor in this case, would determine everything, including the patient need for help. So we have this information asymmetry. مثل إذا سيارة واحدة فيكم اختربت وراحت وقال لازم تبدلين القطعة الفلانية. You wouldn't know. يمكن ما تحتاجون. فنفس الشيء هذا عندنا information asymmetry. We also have uncertainty. Healthcare is provided in a framework where many things are uncertain. The doctor does not know for sure, or the provider does not know for sure that the patient has this. They can only say the most likely diagnosis is X or Y. Because in biology, not everything is not absolute, everything is relative. So we have something that is suggestive of this disease and something else that is happening in the patient. The doctor can, from the big picture, say that patient is most likely have, for example, iron deficiency anemia. And when they begin managing the patient as iron deficiency anemia, maybe something else will arise that change the diagnosis for the doctor. So uncertainty. Also, uncertainty of events happening. So the doctor would, when I say the doctor, I always mean the provider, okay? So doctor, pharmacist, physiotherapist, all healthcare providers, okay? So the provider would give something and not necessarily expect a complication to arise, but it may arise. And also we have externalities. Did you study this? Positive externalities, negative externalities?
No.
So externality is when something leads to something else. For example, in this room, if all of us but one, all of us except one, receive immunization, receive a vaccine, the benefit would cover even this single person who did not take the vaccine, because all of us will be immune and we will not transmit the disease to them, okay? So managing health service is extremely challenging. Okay, so now the health system of Kuwait. First, the demographic profile of Kuwait. All of you from Kuwait here? Anyone not? Okay, but you lived here, right?
Yes.
So you know the society, the system. So the total population in Kuwait is 4.3 million, of which Kuwaitis constitute only 31%, a minority. The population growth rate is 2.78, of which the Kuwaiti population growth rate is 2.26. And the non-Kuwaiti total population growth rate is 3, so even more. The population by nationality, you see most of the population are non-Kuwaiti. By gender, we have around 60% male compared to 40% female. And this because Kuwait is an expatriate dominant society. Many people migrate, they travel to Kuwait, to live in Kuwait, to work. And most of the workforce is male, yes. You see the pie charts of the Kuwaiti and non-Kuwaiti population by gender. Kuwaitis are, as one would expect, 50% for male and female. But non-Kuwaiti, because most of them are workers, they come here to work. So they are 66% of all the non-Kuwaiti population in Kuwait. Did you study this? The
Yes,
population
yes,
pyramid?
yes.
Okay, so did you study this Kuwait's case?
Yes.
So you see the population pyramid of Kuwait is skewed. We have a bump in the age groups between 20 and 60, the working age group, and more towards males.
Yes.
So in the orange. And let's see the Kuwaiti versus non-Kuwaiti. See, the Kuwaiti population pyramid Kuwait is a young population.
Yes.
So it's, what do you call this shape? Bell shaped?
Yes.
You studied shapes of population pyramid. But the non-Kuwaiti population pyramid, I don't know what you call this shape.
Asymmetric.
Asymmetric.
Yes.
Okay, so you see there is a bulge in the working age group. So we have less, we have more males in the working age group. The population by age group pie chart, you see most of the population is in the age group. We are in the working age group. We are a young population. You see the 30 to 44. More than 1/3 of the whole population is from 30 to 44 years of age. The population age groups over time, you see the 30 to 44 is the largest portion, largest subset of the population, and still increasing. And what's decreasing is the 15 to 29. This is related to the population growth rate. 2.78 is low. So the population is expected, if this does not change, to shrink in size. And other age groups are also increasing. You see the 60 plus and 45 to 59, they're also increasing. So the health profile of Kuwait, life expectancy at birth is 75. This is comparable to developed nations. Infant mortality rate per 1,000 is 7.2. This is good, but still can be improved. Life expectancy in GCC nations, you see all GCC nations, they're almost together. Kuwait in the 60s was much better than almost every other GCC nation. But over time, they have converged into one group and almost reached a plateau now. Compared to other regions and groups of the world, you see the high income group, their life expectancy is higher, has always been higher than
Kuwait.
Kuwait is still
Low.
significantly better than the world average, the Arab countries average, and MENA region, you know MENA, Middle East and North Africa region. Okay, cause of death by disease group in Kuwait. So we have ischemic heart disease, has always been the highest, the most important cause of death in Kuwait, and is increasing. And this is this communicable or non-communicable disease?
Non-communicable.
Right, non-communicable disease. We also have strokes. They have always been high and slightly increasing. And as well, important in Kuwait, we have road injuries, the orange line. This is slightly decreasing over the years, but still significantly higher than other populations, other countries. Because mainly we are a young population, we have more road traffic injuries than the rest of the world. And also we have high prevalence of diabetes, deaths due to diabetes, and congenital anomalies. Still, even this I think, is slightly higher than the world average. Maybe this is related to consanguineous marriage in Kuwait. زواج الأقارب ممكن يكون سبب. Did you study DALYs and?
Yes.
Yes. So, disease burden can be described by DALYs and years of life lost and years lost due to disability. So in Kuwait, أنا ما أدري اللي يشوفون ولا لا. شوف أنت قاعد تشوفين؟ تبين تغيرين مكان شو تسوين؟ Okay. So we have ischemic heart disease causing most of the disease burden in Kuwait, and most of it is YLL, not YLD. Why? What
Years
is it?
life last.
Yeah. So why is ischemic heart disease causing loss of life? Not. What is YLL, YLD? What's the difference?
YLL is years of life lost due to death, and years of life due to disabilities is YLD.
So in YLD there is no death,
Yeah.
Yes.
right?
Just disabilities.
Yes. So, but both cause disease burden. Both make the person less able to contribute to the society. So ischemic heart disease, because it is the most significant cause of death in Kuwait, is causing much 40 more than 40 YLLs and DALI. Road injury is also very significant, even though road injury is not the second most significant cause of death, most important cause of death in Kuwait. It still contributes. It is the second most important DALI contributor in Kuwait. Also, one important, diabetes. Years of life lost in diabetes are very are very little compared to YLDs, but still, years lost due to disability are important in diabetes because it makes the person incompetent, disabled, unable to contribute to the society. So the Kuwait health system. I'll go through the elements, the components of the health system, and we can comment on each as we go on. So we have healthcare workers, physicians, nurses, other healthcare professionals. Physicians, the physician density per 1,000 population is 2.4. This is compared to, for example, 2.8 in the UK. So this is not bad, this is good. Nurses, 5.9 per 1,000. And this is small, this is a small number. So policymakers would want this number to be higher. But this is small because of many factors, including we do not have local schools, or we're not producing enough training output of nurses, of nursing professionals than we need and we aim. And because most of them are non-Kuwaiti, so we are competing with other nations, other health systems who also employ, like Qatar, Emirat, and so on. See, this is compared to 9.8 in the US, for example. And other healthcare workers and professionals like pharmacists, dentists, physiotherapists, and so on. As we see, there is huge reliance on non-Kuwaiti health professionals. 62% of all physicians are non-Kuwaiti, and 94% of nurses are non-Kuwaiti. And this can be problematic because those workers coming from all systems come from different cultural backgrounds. Many of them have not maybe ever worked with an Arab person, Arab family. They come also from different training backgrounds. Some come from North America, maybe, and some come from Europe, and some from Africa. So the principles of practice likely are different in each of those training places they come from. And what adds to the problem is that there is no national equivalency system in Kuwait. ما في امتحان معادلة يعني. So once a person has, for example, Bachelor of Nursing, they can just come. We do not know whether this so-called Bachelor of Nursing is good, is up to the standard or not. We do not know this because we do not have a national equivalency system. So this is a gap in our system. Also, there is so-called educational mismatch. And this is a chronic problem in Kuwait. The educational system is not tied to the needs of the system, of the employer's needs. So maybe we need more nurses, but we do not have a nursing school. And maybe we do not need dentists anymore, but we have a large school of dentistry, and so on. And also, the education does not systemically match needs of the job. So one would find themselves to be, when they first work in a job, needing to learn many of the skills required to go on to produce their, to do their job. So education in Kuwait, many schools, does not equip the person with the skills needed for job. Many of the educational programs are as such. And also there is no single body in Kuwait that is responsible for governance of education for healthcare professionals. We have KIMS, you know KIMS? So KIMS, معهد الكويت للاختصاصات الطبية. Kuwait Institute for Medical Specialization, it is the supreme national body responsible for medical education. So medical and dental education. So only for أطباء الأسنان. But we do not have an equivalent body for nurses, for physiotherapists, for nutritionists. So nobody governs this. What is, for example, the minimum educational requirement? What is the minimum set of skills or knowledge that a nutritionist should have for them to practice, or a pharmacist should have to practice pharmacy in Kuwait? We do not have this, and this is also another gap. Okay, healthcare facilities. Any questions? You can ask anytime, okay? Healthcare facilities. Hospital beds in Kuwait is around 8,300. I think this number is now outdated with the new openings, new hospital openings. Around 84% of beds are in MOH hospitals. So the very significant majority of all hospital beds are government hospitals or MOH hospitals. And around 13% are in private hospitals. Hospital beds per 10,000 people is 21. This is compared to, there is variation. See, around 13 in UAE, 12 in Qatar, and 26 in the UK. So Kuwait is faring maybe better than GCC nations in this metric. The population per bed ratio, so how many number of people have one bed in the system, is around 500 in Kuwait. This is in Kuwait, this is compared to 480 in 2013 and 460 in 2011. So this number is increasing, meaning we have now less beds per population than we had in 2011. And there is a global decline. So this is happening in a background where there is a global decline of hospital beds per capita. See, this is Kuwait in orange compared to other countries, hospital beds per capita. So there is a slight decline throughout the world. We have less beds per people per capita now than we had, say, in 20 years ago. Okay, government departments. So هذه إدارات الوزارة، وزارة الصحة، أو حتى الهيئات الحكومية العامة مثل هيئة البيئة أو الهيئة العامة للغذاء والتغذية. So those government departments are departments that primarily focus on health, improving health, regulating health, protecting health, the functions of public health. So we have maybe a department or two that are responsible for communicable disease control. منو عنده أمثلة على هذه؟ منو يعرف؟ عندنا مثلا في وزارة الصحة قسم اسمه قسم صحة الموانئ والحدود. So any non-Kuwaiti person coming to work in Kuwait would have to, for example, have some checkups before they can enter the country. Environmental protection. So كان في قسم اسمه صحة البيئة مثلا، في الهيئة العامة للبيئة EPA. health promotion عندنا إدارة تعزيز الصحة مثلا. And this function maybe is carried out by many organizations, not only health promotion department. And occupational safety يمكن درسكم أو بيدرسكم دكتور أحمد الشطي باكر. باكر. يمكن I think next lecture.
يوم الثلاث.
L25 صح؟
إيه. هذا حق nature communities.
Healthy cities يمكن صح؟
عن
الأنصار
الجغرافيا شيء.
لا هذاك الأنصاري اسمه
وهي غلط
لا
أساسا.
Okay, so we have a department in Kuwait responsible for occupational safety. So most of those departments are MOH departments. They are in the Ministry of Health. But also other government bodies include the EPA, Environmental Protection Authority, and PAFN, Public Authority for Food and Nutrition. Generally, those departments are criticized as being disjointed. Their efforts, each of those departments is like working on its own, working alone. So we have much waste. I do some jobs that you also may be doing, and we're not collaborating on this. So this is called siloed approach, like we have silos between each one of us, each one of those departments. Also, the resources directed to public health activities are generally limited. Most of the activities, resources in health are directed towards curative care, towards hospital. Did you study this? Did you come across this? I'll come to this again later. Okay, healthcare financing. So total expenditure on health is 3% of GDP. You know GDP?
Yes.
GDP?
Global development.
Gross domestic product. So 3%, only 3% of the GDP is spent on health. This number, if we compare it to GCC, it is slightly less. For example, Kuwait spends 3% compared to GCC that spends 4 on average total health expenditure of GDP. But this is significantly less than high-income economies, the high-income group of countries, which is 9%. See, this is the high-income group in brown. So Kuwait spends
4%.
3%. GCC on average spends 4%. And see, the world spends around 10%, and high-income group spends around 12 or 13%. I'll go back. But there is no correlation between the amount spent and population health status. So we can describe saying some countries, some health systems spend 7% on health. Others only spend 2%. But we do not know of a correlation. You know correlation? Did you study correlation? We do not know of a relationship between the amount spent on health as percentage of GDP and the population health status. So we can only assume that spending more on health would produce a healthier population. But we do not have evidence to support this. So the total health expenditure per capita per person in Kuwait is around $3,000, and this and is increasing. You see, Kuwait is in orange. From the year 2000 to 2015, we're spending now more per capita on health per capita. Yes.
Yes, oh my God.
And this is, you see, globally this is increasing. You see, Canada, UK, Qatar. في أسئلة? Okay. So healthcare financing, all this health spending, all this, our total health expenditure, 84% of this, a big majority of this comes from the government. 84% comes from the government. This is more than the GCC average of 79%. So only 79% in other GCC nations come from the government, compared to 84% in Kuwait. So in Kuwait, MOH is the main public funder of health, providing 75%. So you see this 84%, this includes MOH and non-MOH government bodies. The orange includes MOH and other, like Ministry of Defense, Ministry of Interior, Ministry of Social Affairs, and so on. But still, 75%, so 3/4 of everything we spend on health comes from the Ministry of Health. And 85% of this is spent on curative care. So 85% of everything that the Ministry of Health spends on health is spent on curative care rather than preventive care. And this is problematic because, and I think you studied this with maybe Joseph, with Harry, because we are not doing anything, almost not doing anything to correct the problem at its root. We only correct it when it arises. So we're not doing good in
We're not
this.
preventing it from
We're not
happening in the
preventing
first
it.
place.
Yes. So we can expect the problems to still arise again and again, and we're only reacting to it. Also, 99%. This is not important. 99% of National Development Plan health budget is dedicated to building hospitals. This is not important for you. Okay, so that was public funding. Private funding include out-of-pocket payments, people going to clinics and paying out of pocket. Non-profit foundations like Desman Diabetes Institute, Patient Helping from Sanduq I'anat al-Marda, and private hospitals, private for-profit institutions. This generally, private, all those sources account for 16% of total health expenditure. And of this, 50% comes from private hospitals. So they take a big chunk of private health expenditure. Okay?
Expenditure.
Spending.
Oh, okay.
Expending or spending. So the private sector is not big now, but it is growing. It is rapidly growing. It's now contributing to private hospitals, contributing to 8% of the total health expenditure in Kuwait. And this 8% is a big number, because total health expenditure, يعني 21 billion KD. No, 21? No, that's not 21.
Right.
The GDP is 21 billion, okay? So 8% of total health expenditure is, I think total health expenditure now is 2 billion KD. So 8% of this is still very significant. Okay, so this is a map of financial flow. This is not very important for those who want to study for the exam. Generally, financing comes from either government source sector or non-government sector. See, government sector, financing agents, we have Ministry of Health, other ministries, and other government bodies. And non-government sector, we have charity like Desman Diabetes, for example, and household payments. Healthcare providers, where healthcare is provided, depending on funding, where the source of funding. For example, you see مثلا Ahmadi Hospital, KOC Hospital in the center there. You see the funds are coming from only one place, other government. So the Ministry of Oil, the KOC, okay? Question? No. And healthcare services provided by each of those providers. Okay, so healthcare financing. Insurance, healthcare, did you study insurance? Not yet?
No.
So health insurance is taking an increasingly larger role in Kuwait in financing healthcare. Private health insurance accounts for 9.5 of private health expenditure. And this is significantly less than GCC average of 26%. Other GCC countries have more developed health insurance, private health insurance schemes. Kuwait is now quickly changing this, so we expect that in a year or two, this number will be significantly more than 9%. So insurance will cover more of the total health expenditure and private health expenditure. I'll go through two models now. Dhaman, you know Dhaman?
Yes.
So Dhaman is a scheme for to provide healthcare for non-citizen workers, for non-Kuwaitis. According to this scheme, so Dhaman is a company that was incorporated by the government and with the mandate to provide care for non-Kuwaiti workers. According to the law of Dhaman, private employers, القطاع الخاص, are obliged to annually purchase health insurance with Dhaman for their non-citizen workers. So this does not, for example, cover non-Kuwaitis who are employed by the government, or non-Kuwaitis who are employed, domestic workers, working at households. Beneficiaries of Dhaman, then once the premium, the insurance premium is paid by the employer for workers in private sector, then they, the beneficiary and مستفيدين, they can access healthcare through primary care centers of Dhaman. So مو المستوصفات مالت وزارة الصحة. Then they can access healthcare through Dhaman primary care centers. Primary care centers would act as gatekeeper. Did you study this word, gatekeeper?
Yes.
So they would act as a gatekeeper, except in emergencies. The beneficiary, the individual, would need to go through the primary care center to access other levels of care in the system. Dhaman will also operate secondary care services, hospitals, but not tertiary care. Did you study levels of care?
Yes.
Primary, secondary, tertiary? No? Do you know what primary and secondary and tertiary care?
Yes, there's no.
Okay, so primary care generally is care that is accessible to the people. Like مثل المستوصفات اللي عندنا في كل منطقة. They provide basic medical care only. Okay? So if one needs to have surgery, they cannot have it done in Mustawfa. Okay? And typically in Kuwait, they are walk-in, so we do not need to book with an appointment to access primary care. And they're easy to reach, they're accessible, they're affordable, they're free almost. Secondary care is care, hospital-based care, مثل المستشفيات العامة. So باطنية، جراحة، أطفال، ولادة، هذه الأشياء اللي الواحد ما يحتاج يكون مشخص فيها. So one does not need to have a diagnosis before they can see a surgeon, for example. The surgeon will diagnose them. Tertiary care is consultation-based services, healthcare services. So one cannot go to tertiary care center unless they have a diagnosis. So for example, يعني حسب الصدري يقدم secondary and tertiary care. مثلا مستشفى الأمراض الصدرية يقدم secondary and tertiary care. So it's the service, levels of care is for the service, not the establishment, not the hospital. So you can find in a hospital, for example, in Mubarak Hospital, they provide secondary and tertiary care services. For example, MBK Children's Hospital, the hospital I work for, is tertiary. So we do not receive a patient unless they have a diagnosis, unless they have leukemia, for example. Only then we see them and provide care to them. Okay? So Daman will not operate tertiary healthcare services. In Daman, beneficiaries can be referred to MOH hospitals for specialty care, for tertiary care. And there is, each time Daman beneficiary access the system, they need to, you see the doctor, either primary or secondary care, they need to pay a nominal co-payment. So they need to pay something at the point of care. I think 4 KD for primary, or 2.5 for primary and 4 for secondary. Any questions on Daman? Yes.
You said scheme. Is that like a good thing or a bad thing about Daman? You said scheme.
Yes.
Doesn't that have a negative notion to it?
No.
عادي.
No, it's generic. Scheme, I mean a system, a framework.
Okay.
No negative connotation. No. Okay, so this is Daman. We have عافية. سامعين بعافية؟
ايه
شنو عافية؟ Yes, so عافية is another private insurance scheme for Kuwaiti retirees, للمتقاعدين. Its beneficiaries, and this is important, continue to have access to MOH facilities. This is not good for one to have access to 2 health systems. Okay? So the system was not designed, in my opinion, was not designed well. One can have access to healthcare services through Afia and health services in MOH and maybe KOC hospital and others. In Afia there is a spending cap at 17K Kuwaiti dinar, 17,000 per beneficiary. And it is not clear where this 17K cap come from. We do not know if this is based on evidence or just a hunch. We don't know. And this is problematic because some Afia beneficiaries are sick and they need more care than others. Maybe they need more than 17K worth of healthcare. And also having this cap, especially if it's not based on evidence, would create would influence beneficiaries' behavior in a way that they may seek care only to max their cap. فاهمين قصدي بعدين؟ Only because they can. They don't need the care. But because before this year ends, I have, for example, 4,000 dinars worth of healthcare, so why not spend them? So this is problematic. And MOH plays no regulatory role in Afia. It just provides block funding. So the role of MOH is very limited in Afia. And there are plans now to expand Afia, to include other subsets of the population, like persons with special needs, for example. Questions on Afia? Yes?
What do you mean by cap?
Cap, upper limit of spending. So you have, for example, كم يوم لازم حدكم تغيبون يلا تدشون امتحان؟ 20%؟ هذا كاب. Limit, yes, upper limit. So إذا غبتوا 21% ما تدخلون امتحان صح؟ فهني في كاب حق الفلوس 17,000. Questions? Yes.
ليش is it bad to have access to both facilities?
Because it will be abused.
Okay.
Because one would be abused. 2, it limits so-called coordination of care. If I follow up with 2 doctors, my doctor in MOH wouldn't know that I am already on this medication, and maybe he will prescribe this to me, which can create drug interactions and so on. Okay. Okay, functional organizations of health services. So generally, MOH, Ministry of Health, can be divided into those 2 functions: public health functions and healthcare provision. So the Ministry of Health only does those 2 things only. Has public health function, الإدارات المركزية أو الإدارات العامة. For example, إدارة الجودة والاعتماد, إدارة الصحة المهنية, إدارة التراخيص الصحية. So إدارة تعزيز الصحة. Those departments regulate every aspect of health or related to health. For example, health licensing department regulate who can provide health. In Ministry of Health or elsewhere, it regulates. For example, if I want to practice medicine, I need to have, for example, a medical degree. I need to have whatever check for my blood, HIV, hepatitis B negative, whatever. I need to have some competencies in order for me to practice. Department of, for example, occupational health takes care of, for example, occupational health and safety in companies. What are the minimum requirements of, for example, مثلا يعني عدد toilet per staff or hour of break in a work day and so on. I say this, I'm not commending the Ministry of Health. So those are the roles that should be practiced. In fact, in practice, in actual life, they may not be practiced to their fullest extent, like everything. معاي في هذه؟ يعني الحين هذا اختصاص وزارة الصحة. في الواقع واحنا كلنا يعني عايشين بالكويت. في الواقع عادي الوزارة مقصرة في هذا. بس هذا الحين الاختصاص. So this department is responsible for this function or that. Maybe they are not. Maybe they're not doing their job as well as they should. So this is one function, public health function, all those departments. The other division, branch of the division is healthcare provision. Providing healthcare, providing health service to people. So one is regulating, mainly regulating. Of course, there is some provision in public health functions, depending on the department. Main provision of primary, secondary, tertiary care is in health, is in the other function, which is through health regions. You know health regions, المناطق الصحية في الكويت. So I'll come to this. So Kuwait is divided into 7 health regions. هذيل يشابهون المحافظات بس شوية مختلفين. So عندنا منطقة العاصمة الصحية، حولي الصحية، الفروانية الصحية، الأحمدي الصحية، الجهرة الصحية، مبارك الكبير الصحية، والصباح التخصصية. الصباح منطقة الصباح ما فيها كل المناطق ما خلوا الصباح الحين كل المناطق هذه فيها primary care وسكندري كير. الحين حتى مبارك كبير ما يخالف شنو الخمسة اللي فوق كلهم فيهم primary care وسكندري كير، فيهم يعني مستوصفات كل واحد فيهم تابع وفيهم مستشفى عام على الأقل واحد. فاللي ساكنين مثلا بالفروانية حسب منطقتهم عندهم مستوصف في المنطقة وعندهم إذا احتاجوا شيء يروحون مستشفى الفروانية. بس يمكن ما عندهم مثلا فروانية فيها كل شيء. اللي ساكنين بالأميري مثلا يمكن ما عندهم بالأميري طبيب عيون إذا احتاجوا شيء أو جلدية مثلا، فيمكن يروحون مكان ثاني. ونفس الكلام مبارك يعني مثلا وحدة احتاجت مثلا طبيب ولادة ما في مبارك، فحتى لو هي ساكنة بالجابرية تروح المستوصف ولا مستشفى مبارك بعدين تروح مستشفى الولادة يحولونها مستشفى الولادة في منطقة الصباح مثلا. منطقة الصباح is tertiary, almost tertiary care hub. كل التخصصات الطبية موجودة في منطقة الصباح but there is no primary care. فمنطقة الصباح
ماكو مستوصف،
ما فيها مستوصف،
مستشفى عام.
كلها مستشفيات تخصصية وفي طبعا مستشفى عام مستشفى الصباح.
هل فيها المناطق الوبائية وكذي؟
Okay, so healthcare delivery levels تكلمنا عن هذين. So primary care مثل ما قلنا is the first point of contact. It has a gatekeeping function, high access, local community. It's close to the local community, and it is a walk-in service. Secondary care is mainly for acute care, and it is hospital-based. And tertiary care is specialized consultative care. Typically works through referral or transfer from secondary care. So one cannot just go to, for example, cancer surgeon and tell them I have cancer. No, they should have a diagnosis made by a doctor before they are referred to tertiary care. So the health system, is this a health system? Some would argue it's mostly healthcare. As we said, 85% of all public health spending is on curative care. So it's mostly health care system, not health system. And some would argue it's actually illness care because the system is reactive. It's only reacting to illness. It's not promoting health or protecting health. So is it a system? Some would argue it's more of a network of rather uncoordinated elements in the network. We have a department of, for example, quality and safety that may be overlooking the quality and safety of hospitals, but producing some other documentation or some other policies. And we have maybe a department of health licensing that is not maybe aggressively licensing healthcare providers in the private sector, and so on. So some would argue this our health system is more a network than a system. Is it public? I would say yes, because our providers and our funding bodies are both mainly public. We have public funding. Most of the funds come from the public and of public providers. Most of healthcare workers are employed by the public healthcare. This is not, for example, in Canada, it's not like this. In Canada, physicians are not employed by the hospital. They're paid maybe by the hour or by their performance and so on. So our system is public funding of public provider. Compare this, for example, to Canada, public-private. So providers are private, mainly private. Of course, there are public providers, but mainly private. US, private funding mainly through insurance of private providers. So we are closest, in this regard, we are closest to the UK system. Okay, health system challenges. Okay, those slides are important. Okay, challenges. I know تلاحين شوية لازم تمشون صح؟ Okay, so I'll go through them quickly.
These are important?
Yes.
Okay.
So health system challenges. What are the challenges of the health system in Kuwait? Governance. We have high power distance culture and hegemony of national culture. I will not go through detail of high power distance.
Okay.
But in general, the outcome of this is that we have favoritism, we have nepotism, we have our policies. Most of the time, many times, they are not the result of evidence-based decision making. Maybe because some political leader wants some employee to be in this position, and the whole system would be influenced toward this. MOH is the main funder, provider, and regulator. So MOH is wearing many hats. So it is regulating something that it is providing. So في تعارض مصالح, there is conflict of interest. Ministry of Health is funding the healthcare services and providing them and regulating them, which makes its regulation questionable. And private sector is not sufficiently regulated. It almost is swimming in its own sea that is not regulated by the Ministry of Health. Of course, this is all relative. There is some regulation. But some would say it is lax. It's not as tight as it should be. Financing. So the government expenditure as a proportion of total is high, and this is not sustainable, especially given the increasing prevalence of non-communicable disease, and especially given that much of this funding source comes from the oil revenue, which itself is changing secondary to the oil price. Also, because the Ministry of Health both fund and provide care, this is called direct provision model. This is inefficient. This because, for example, the providers at the Ministry of Health are salaried employees. They do not care whether their clinical decision waste resources or not. They will take the same amount of salary each month, whether they see 1 patient a day or 100 patients a day, whether they prescribe, over-prescribe or not. So this system, the direct provision model, produces inefficiency. Okay, so this is not efficient, and inappropriate care and over-prescribing. Also, budgeting in Kuwait in the health system in Kuwait is inefficient. It's not based on needs. It's a block fund that is a block contract that is given to, for example, the Ministry of Health. So at the beginning of the fiscal year, the Ministry of Health is given, for example, 1 billion or 2 billion. And the Ministry of Health cannot or does not have the ability to predict what will happen in this year. We do not know if, for example, some pandemic hits Kuwait. This cannot be forecasted efficiently. So our health funding system is very primitive. Other countries have worked with pay for performance. Did you study health financing? Yes. Health. So there are more developed systems like diagnostic related groups, for example, and payment for performance, and so on. So in Kuwait we do not use those systems. The government the Ministry of Health is given a chunk of money that it can spend. So it's very primitive. Okay, workforce. As we said, there is huge reliance on expatriate workers with different cultures and different training backgrounds. We do not have a national equivalency system. There have been some reported cases of workers, healthcare workers, entering the system with falsified documents. The system currently, at least in the Ministry of Health, one would work provisionally بشرط عقد فاسخ يسمونه في شرط فاسخ على ما يعادلون شهادته. And it had happened in the past that someone works for 8, 9, 12 months, then الشهادة لم تعادل. But after they have provided care and dealt with patients and so on. So this system is primitive. We have no national equivalency, and there have been some reported cases of falsification. Also, Kuwait is competing with other countries, at least in the region, for expatriate workers. We need nurses, and also Qatar and Saudi and Oman. And maybe we cannot always compete maybe with Qatar or Emirat on salaries. So this is a challenge for the system. Also, the process to hire highly skilled expatriate physicians is very bureaucratic and burdensome. If we, for example, all physicians, for example, receive salary according to their rank. استشاري ياخذ هالكثر، اختصاصي هالكثر. So even this is primitive. This is very simple. So في استشاري مثلا في الجراحة يمكن يشتغل أكثر من استشاري في طب العائلي مثلا. But they're all the same in our current system. So sometimes we need, for example, a heart surgeon, and we do not have one in Kuwait. So the Ministry of Health would negotiate with someone from the States. Then they would be hired on a special contract. This contract is the bureaucratic process for this contract is very long. So it takes sometimes years for the contract to be finalized. So what do providers do? What do hospitals at the Ministry of Health do? Many times they hire physicians on short-term locum contract. Locum, سامعين locum?
Okay,
So
yes, yes.
locum contracts are short-term contracts in which the provider provides not only a salary for the contractor, but also board and lodging. يعني يجي واحد ويحجزوا له فندق وسيارة ويوصلونه كل يوم, which is very expensive. So this is also inefficient. As well, there is a lack of public health skills in general in the system. The interest in public health is recent, in Kuwait at least, is new. Many of those in management positions in Ministry of Health or in the health system have not received any specific training in management, in health management or health policy. So they just were promoted to be managers or directors without maybe necessarily the prerequisite knowledge of this job. Service provision, equity. Did you study this term, equity?
Yes.
Okay, so many would argue the system lacks equity, is inequitable. We have a multi-tier system. Kuwaitis would receive one tier of care, non-Kuwaiti another. The list of drug lists, there is a drug list only for Kuwaitis. We have also disproportionate distribution of resources. For example, we have more trained doctors in حوالي الصحية والعاصمة الصحية than we have in الجهة الصحية والأحمدية الصحية. So the system is not well, in my opinion, is not well managed in this regard. We have disproportionate distribution. دكتور يقول أنا بشتغل بهالمكان. And the system lets this, it's very lax with those behaviors. Also, service quality, there is variation in practice. So one of us would go to one doctor who would prescribe something, and another doctor would prescribe something else. There are almost, in practice, no guidelines of care. So, حظك نصيبك. So, and this is a huge problem. This is a challenge for the system. We should have guidelines of care. Guidelines of care. So what the provider should do, this is called guideline of care, for each condition. For example, patient with chest pain. The provider should not every time assess كنا ودي أعطيك الدواء الفلاني. ما يصير كذي. We should have clinical practice guidelines for care of at least common conditions, and then this should be enforced. This should be enacted. So providers should actually follow those guidelines if they are present. This, over the years, had resulted in negative public image of the health system. So many of you, maybe all of you, would not say that you trust the health system in Kuwait or the Ministry of Health facilities. Mainly because of this, of variation in practice and poor service quality. Okay, access, we have good access. Okay, anyone can access, but access, you'll study this, I think, next year. Access has many dimensions. So there is physical accessibility, that the primary care center is near my home, I can just walk. But there is also affordability, there is also other dimensions of access. For example, those who cannot speak neither English nor Arabic, we do not have translators in our centers. Those who cannot pay, non-Kuwaiti who cannot pay, cannot access the system because there is a payment at the point of care. So the access is hindered, at least in some areas in the health system. This is the last slide. The health system was designed for communicable disease era. It typically focuses on inpatient beds, isolation rooms, non-integrated services. This is not This is not like other modern health systems now. So we do not have integrated services. One would, for example, a patient at our hospital, if they need something small, maybe CT scan at another hospital, or a chest tube insertion, or some procedure, they would need to be discharged from the hospital, moved by an ambulance to the other hospital, have a file created for them at the other hospital, even though they just need this one transaction, have the procedure done, then come back. So the system was designed for an era that may not be applicable today. Also, the civil service code is very rigid. We spoke about this in locum contracts and bureaucratic process for hiring highly skilled professionals. Also, typically, our training, for example, training resources are typically directed towards healthcare professionals, maybe only medical professionals. The system does not focus on, for example, training or increasing the competency of non-health professional workers. For example, administrative staff or financiers and other healthcare workers. And also we mentioned this, we have unified remuneration اللي هو الرواتب على الدرجة مو على الشغل ولا على طبيعة العمل على الدرجة for each category of healthcare professionals. And this is not inviting good workers, skilled workers who can find jobs elsewhere. Why should they be equated with others who maybe would not do as much work? Okay, questions? Thank you.
Thank you.
اللي عنده سؤال اللي تحب تسأل ممكن تدز لي ايميل على هذا الايميل. أنا